Hello, my name's Dr. Michael Weber, and welcome to NKF Kidney Talks. For this edition, I'm going to be talking about hyperkalemia in primary care practice, a problem that is more common than many people suspect. Why are we so concerned? Why do we talk about it so much? Well, we know that once the potassium gets above 5, and certainly into the range 5.5 on up to 6, we see a big increase in the risk of major cardiac arrhythmias and even fatal outcomes. A recent report found that patients who have evidence for chronic kidney disease, in other words, GFRs less than 60, on average there was one event per year. And even for people who didn't have chronic kidney disease, but were taking blockers of the renin-angiotensin system, ACE inhibitors, or angiotensin receptor blockers, or agents like spironolactone that block aldosterone, there was, on average, about one episode every 3, 4, 5 years. If you think about the patients in your practice who have some evidence for kidney disease, and all the many patients in your practice who are taking those kinds of drugs, the ACEs, the ARBs, and so forth, it wouldn't be surprising to figure out that 3, 4, 5 times a year, at least, you're going to see this kind of problem among your own patients. Let's ask the big question: what are the risk factors? What are the things that bring about hyperkalemia, or at least the risk of it? We've already talked about a couple of them. Chronic kidney disease. Any GFR less than 60 is a problem. And if you think about it, if you look at your lab reports, you're going to see quite a few patients in your practice who have a GFR less than 60. You're not worrying about them yet in terms of end-stage kidney disease or even relatively advanced kidney disease, but nevertheless, these patients are vulnerable. Diabetes, well, you don't need me to tell you that diabetes mellitus, particularly type 2 diabetes, is very common. And you probably have a large number of patients who, for that reason alone, could be at risk for potassium issues. Heart failure, particularly decompensated heart failure. Yes, I know that by the time people have advanced heart failure and on multiple drugs and dealing with all sorts of complications, they're often in the hands of a cardiologist, but not always. And I suspect many of you do take care of patients with pretty advanced heart disease and particularly heart failure. Again, hyperkalemia can very easily intercede. And even treatment-resistant hypertension. That's an odd thing to say because if you think about it, hypertension per se doesn't cause hyperkalemia. But remember, more and more people are treating these difficult hypertension patients with spironolactone. And spironolactone can be a big cause of hyperkalemia. So again, watch out. And advanced age. Once again, you don't need me to remind you that your waiting rooms are full of people in their 70s, 80s, and beyond who, again, are very vulnerable to hyperkalemia. So these are the background treatment conditions where these sorts of problems happen. But there are also treatment issues, things that we can perhaps govern more easily. I've already stressed drugs that block the renin-angiotensin-aldosterone system are a big factor in hyperkalemia, particularly when they're used in combination. We'll get to that in a moment. But apart from the ACE inhibitors, the angiotensin receptor blockers, beta blockers, don't forget they also block the renin-angiotensin system. We've talked about spironolactone and eplerenone. They also can do that. And perhaps the biggest causes of hyperkalemia, because they're just so widely used, we often don't know that our patients are taking these drugs, the non-steroidal anti-inflammatory agents, ibuprofen, naproxen, and so forth. They affect the kidney and they can lead to hyperkalemia. So it's an easy story to understand why hyperkalemia all of a sudden is becoming a common and troubling issue. So what can we do to prevent it? Well, some easy answers. First of all, many of our patients do tend to take potassium-containing supplements, sometimes by intent, sometimes because they are used as substitutes for common salt, for sodium, because patients want to be eating less sodium. Well, we don't want them to be eating too much potassium either. If we worry about hyperkalemia, we could prescribe a low potassium diet, which is a bit counterintuitive because if you think about it, a low potassium diet means avoid fruits and vegetables, fresh produce, all the healthy foods that we normally encourage our patients to focus on. Now all of a sudden we're saying, keep away because we don't want you to be exposed to that much potassium. Clearly, we can try and encourage patients to stop taking their NSAIDs, their ibuprofen, naproxen, and so forth, for their aches and pains. Not always possible to completely get people off of these agents, but we should do the best we can, particularly if we're worried about potassium. And if we're going to be using treatment for hypertension and using diuretics, which we're going to be using a lot of the time, please remember, if you're going to be using hydrochlorothiazide, 12.5 milligrams isn't getting rid of much potassium, and if a patient's got a high or an increasing potassium, you may want to use higher doses or switch to chlorthalidone, which is a more powerful agent. And if you're using loop diuretics, furosemide 40 milligrams once a day doesn't really cut it. You need to give it twice a day, or else use a long-acting loop diuretic like torsemide. And if you are using ACEs and ARBs, and most people should be getting them, and remember, these are the drugs of choice for people who have chronic kidney disease, so there's no avoiding their use. Likewise, in heart failure, we're going to be using these drugs. Bring the doses down, particularly if you're worried about potassium, and check that potassium pretty regularly to make sure we're at a stable point. Certainly, anytime you change doses of ACEs or ARBs, check a potassium soon afterwards. And if you're using combination treatment, an ACE or an ARB plus an aldosterone blocker such as spironolactone or eplerenone, do not use that combination if the GFR is below 30. That's a no-no. And if the potassium is rising up to around 5.5, again, it's a good idea not to use that combination. You usually stop the spironolactone and just stay with your ACE or your ARB. And if you ever get to above 5.5 with potassium, stop both of those types of drugs, and we'd have to, at that point, rethink the whole therapeutic strategy. So what do we do if the serum potassium is getting too high and is starting to look as though it might be heading up for 6? My immediate response to that question is to say, I would probably want that patient to go to an emergency room, because if I'm worried that we could be looking at a major arrhythmia with possibly fatal outcomes, I want that patient where they can get the best possible help as quickly as possible. Remember, there are only 3 ways in which we can get potassium out of the body. The first is using diuretics. We've talked about that, the importance of using effective doses of strong diuretics. Second way to get potassium out of the body is through dialysis. And let's leave that conversation for the nephrologist. That's out of our bailiwick. The third way to get rid of potassium is with resins. Drugs that work in the bowel, they don't get absorbed, they bind to potassium, and they hold it in the bowel, and that works to get potassium out of the body as a whole. Again, it's the nephrologists who seem to be on top of that form of approach. You might hear that it's a good idea to give people with high potassium infusions of insulin or the beta-2 agonists or sodium bicarbonate. Well, those drugs do work temporarily by driving potassium from extracellular space into cells. But that only lasts a matter of minutes or an hour or two. That doesn't get potassium out of the body. And in the end, we're going to have to do something a little bit more powerful in order to get where we need to go. Let me remind everybody that hyperkalemia is a very common issue in primary care practice. So many of our patients are susceptible. All of our patients who've got impaired renal function, people with diabetes, people taking blockers of the renin-angiotensin system, the ACEs, the ARBs, drugs like spironolactone. It's very hard not to see hyperkalemia. It shouldn't be that difficult to anticipate it and hopefully to prevent it. Thank you very much for your attention, and I wish you well in your practice.